Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record near the back of the auditorium, and also please remember to fill out the program evaluations that you picked up on the way in. And please give us any ideas that you might have in regards to future topics or future speakers. Today I have the pleasure of actually reintroducing Dr. Greg Welk. Dr. Welk received his Ph.D. from Arizona State University, and he is currently a professor in the Department of Kinesiology at Iowa State University. He has been very extensively published and is a well-recognized authority on the topic of exercise and wellness, and we're very happy that he was able to accept our invitation today to review with us exercise as medicine. And please join me in welcoming Dr. Greg Welk.
Thank you. I'll presume this is on. So thanks again. So as Dr. Halberg mentioned, I gave a talk about 4 or 5 years ago, same location. I hope, and it's totally new, but I do have similar stories to tell. But the content of what I'll be talking about is, I think, relevant to clinicians and the hospital and the medical system, and it's exercise is medicine. But I like to add a whole lot more, because if you say that exercise is just medicine, then it reduces the real value of exercise to a small outcome, whereas in reality, exercise is a lot more than that. It's quality of life, and how it makes you feel and sleep better and feel better. So that's really the message. If I wish I could say I can take credit for the exercise is medicine concept, but I cannot. It's actually a national and international initiative sponsored by the American College of Sports Medicine. That's the leading professional organization for kinesiology faculty like myself. And they started this about 10 years ago, and it's really amazing to see how it's taken off. And I'll go through kind of what the goals of that national and international initiative are. So I'll focus a lot more on that. But they also offer or recommend that departments of kinesiology like mine offer a campus initiative, and we do that as well. So I lead a group of students, and we have a whole departmental initiative around exercise medicine on campus. And the goal of that is to do the same thing, create the buzz and energy about exercise on both for our clinical team and lead student health, or the student health center and the rec center and things like that, and promote that visibility on campus, but also to promote it in the community. And so, but instead of using this official logo, we like to use this one. So we brand it with Psy. Just like everyone, it's amazing how many words you could spell with Psy, but we choose to spell exercise, C-Y. Even on my computer, if I start typing exercise, it defaults to this, not the other way. So I'll tell you a little bit about both initiatives, the national one and then our local campus effort. And what I left a couple handouts at the top because there's some things we're doing locally or on campus that I'd love to do in partnership with McFarland and Mary Greeley. And so I'll refer to those handouts, and you could pick one up later as you go. But I wanted to kick it off. I'm not going to throw a lot of facts at you because I think the facts are so overwhelming that I don't want to just show you more data. What I'd rather do is show you what the initiative is about and how it works in clinical settings and how it can work. And I'm happy to have follow-up or answer any questions you might have or see where that leads. So the first reason, I'll throw some cartoons at you, but this is the nature of how people view physical activity and exercise. And I like to say it's not just a little good for us, it's really good for us. So imagine how powerful the effects of exercise would be if we can really measure it well. So my main area of research is trying to figure out how do you quantify it. I do a lot of work with Fitbits and activity monitors and self-report, but if I were to ask you, how active are you? You'd throw out numbers and you'd say, well, I'm pretty active, but we can't measure it as precisely as you can blood pressure, for example. And so when you link blood pressure to clinical outcomes, it's really strong because you can measure it well. So physical activity is so powerful that we can even have very powerful clinical outcomes even though we can't measure it that well. And that's even though there's error in the measure, we can still show strong associations. But this is how it's perceived. In this case, the doctor says, Mr. Big, you have sedentary death syndrome. And that's actually a word that's been coined in the casual vernacular. There's obviously not a real thing called sedentary death syndrome, but there really should be because it's that powerful of an effect. Like physical inactivity is a contributing cause of death and many other chronic diseases, and it's just overwhelming. So if the doctor were to walk up to a patient and say, you have sedentary death syndrome, maybe it would get more attention, right? But instead we say, yeah, you should be more active. And the patient's like, oh, good, I don't have this, but I'm just, some other time, or exercise isn't that important. So in this case, the patient says, thank goodness my wife just claims I'm fat and lazy, so I'm not going to do this exercise stuff no matter what you tell me. So that's really what exercise medicine is about, is having the clinician provide that powerful impetus to get a patient to maybe consider taking action on physical activity. And I'll show you more examples of this. But this is how it's perceived in the media. So this was a cover on Time, and it's actually a decent article, but people never read past the cover. And it says the myth about exercise. If you read the tagline, I'll go closer. It says, of course it's good for you, but it's really what you eat that matters. And I couldn't disagree more. It's really how physically active you are, because if you're physically active, you can be healthy regardless of your body size, what your weight is, and regardless of what any other risk factors you have are. And I can show you evidence of that. But again, they were highlighting weight control. And sure, weight control is strongly influenced by what we eat, but physical activity is what has a stronger impact on health. So there's, again, powerful data. But people might have read the myth about exercise, and they said, oh, good, now I knew it was too good to be true, and I knew it wasn't really that important for me. So they kind of moved past it, and they never really read the article. But then recently, the Time just came up with an article that says the science of exercise, and obviously it is really powerful, and I put a little tagline at the bottom and said maybe they felt guilty about the past cover and wanted to make up for their past grievances. But again, the potency of exercise is so strong that it's overwhelming. So I don't want to go through a lot of that. How many are familiar with the fact that national physical activity guidelines are coming out this fall in 2018? Has anyone heard of this? So the physical activity world has been waiting for this for a while. The first guidelines came out in 2008, and just like the dietary guidelines that come out every 5 years, the new physical activity guidelines come out every 10 years. And so there's a whole advisory board committee, and those reports are already online, and the final versions of the recommendations are coming out this fall, probably by November. So keep alert for those, and that's where the official statements will be on the recommendations for the public. And these, again, come out of the government. These are government guidelines on physical activity for all populations, and it'll have the updated data on how potent it is for various health outcomes. So I'll wait and let you see those headlines. But I did want to share this figure with you. This is probably the most cited article in our field by a colleague of mine, Stephen Blair, and this shows the potency of physical activity on all-cause mortality. And so what they do in this study is they had thousands, like 30 to 40,000 people that have a maximal stress test done at the Cooper Clinic, and these people are followed for life to look for causes of death and mortality over time. And what they've done, and they've done many studies on this, but this is one of the most potent, is they divide people's fitness into 5 quintiles, and the lowest quintile you see has a 2 or 3.5 times greater relative risk of dying than any of the other quintiles. So that means that you really just have to get out of that bottom 20%. If you're in 21%, you're probably okay, if you look at the data. That's how potent the effect is, but it's really targeting the major risk that happens to the 20% of the people that are at the bottom level of fitness in society. You see there's kind of a plateauing effect that you don't get that much more bang for your buck beyond that. And at that point, you start exercising for other reasons. And I always like to tell students, I'd exercise if it was bad for me. Anyone with me? What if a doctor came up and said, I don't want you to exercise? I'd be like, I don't know, I'm sorry. I can't not do it. So that's how important it is for the whole lot more. I would exercise even if it was bad for me. And some people could argue, okay, at extreme levels, like marathon running and maybe some extreme levels, there's risks that people take for the benefits, and they might exercise again for reasons other than health at that point. But the main point is that we would do the public health a lot of good if we can get those 20% to move into the middle category and just be a little active, and it doesn't take a lot of physical activity to get there, to move out of that 20%. So that's one of the most highly cited papers in our field. The real beauty, and I highlight that again, how can the evidence be any clearer or more powerful than that this is potent? Well, it can get more powerful because actually the benefit of physical activity works regardless of body size. And this is what I think a lot of people aren't aware of. A lot of people presume that exercise works because it helps you lose weight. Well, that's great, but it's really difficult to lose weight. And so exercise is so powerful that it works independent of whatever weight category you are. And if you look at the figure, so the light pink shows the unfit category, and you look at all 3 body weight categories, lean, normal weight, and obese, and the relative risk is the same regardless of if you're unfit. And if you're fit, notice that regardless of what your body size is, your relative risk is lower. So the key determinant there of risk is really fitness, not fatness. And so again, it protects you from health risks associated with obesity. So if you have overweight patients, you can encourage them to lose weight, but you can also tell them, look, all you have to do is be physically active and you'll have reduced health risks regardless of what weight you're at. And that's a really powerful message because a lot of people say, well, I just can't lose weight. I've tried, it doesn't work. And so again, exercise is so powerful that it works regardless of weight status. Okay, and there's many studies that have documented similar findings. I'm just showing a couple. But yet people go out of their way to avoid it. So this is where we're at. So this, what side of the stairway would you be on, the left one or the right one? So I marvel at this all the time. A lot of you probably fly out of the Des Moines airport. What do you see when people go when you land and you walk down? Everyone funnels down to the escalator. I'm the guy that takes the stairs. So I'd like to challenge you, the next time you go to the airport, think about it and say, I'm not going to get on that escalator. I'm going to take the stairs. Because maybe somebody else behind you sees you and they say, maybe I should take the stairs too. But for the most part, we're a herding mentality and people just follow along and they go down the escalator. They don't need to be on the escalator and they don't really think about it. But you should look for a way to be physically active in society and seek it out. Society robs us of physical activity by forcing us into cars and sedentary jobs and many other scenarios. So you have to look for ways to get your steps. And if you're worried about carrying your luggage, well, then that's your weight training. So carry that luggage up the stairs. So I think you get the point there, but people go out of their way to avoid it, and we have a lot of work to do. So what about quality of life? You can say, well, yeah, exercise is good for me and all that, but what about quality of life? Well, there's data to support that as well. This is a randomized controlled trial comparing different groups on different indicators, and it's really difficult to assess quality of life, but they had reasonable indicators. And if you look here, they had a control group and 3 different levels of exercise, and regardless of what group you're in, you're better off than the control group that didn't get anything. So the key point is that your mental health went up. That's change in mental health. So however they assessed it in depression indicators and things. So that was a benefit of quality of life, and they also did the same for energy. Notice regardless of what activity group you're in, you had a bigger change, a benefit in energy versus the control group. So these are the untangible benefits that I point to when I say exercise is medicine, but a whole lot more. So I'll lead you to this and say, again, what if there was one prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, and obesity, and it was fun, and it made you feel good and sleep better, and was also enjoyable socially? What if there was one medicine that could do that? And there obviously is, but why aren't we doing it, right? So I'm going to give you, as your local medical rep for exercises medicine, I brought along sample drugs, just like you can go to your pharmaceutical group, and I'd like you all to take a sample of Exertol. This is your medicine, and it looks like a drug box, just like you get from a pharmaceutical rep, right? So I'm your local exercises medicine rep, and if you look on here, it says it may leave you feeling energized, take with a healthy diet, work up a sweat, don't give up. Warning, this prescription may result in weight loss, improved health, better self-esteem, and quality of life. Do not keep out of reach of children. Right? So we had fun with this, and you'll if you shake it, by the way, also take one of the inserts. If you haven't gone back and take one of the inserts. And so if you, the insert, most medicals tell you all the contraindications in really small print of what can happen if you take this and the side effects. What are the side effects of exercise that maybe you'll get addicted to it, right? So it does have the same properties of other drugs. There's a dose-response effect. It works on various biological systems, and there's potential for addiction, which is a positive addiction. But we instead put an insert in to give you facts about exercise and benefits, and we can make these available to you guys. If you think there's patients that would like these, we can make these more available. This comes out of our student group, so you can see our logo, Exercises Medicine, on there, and again, we can make these available for you to distribute to patients as a awareness tool. By the way, if you open up your box, there's one that I planted a little piece of paper in, so you have to open it. If any of you happen to have the word winner written on a little yellow sheet of paper, I'll give you a shirt just for fun. Hey, there's the winner. So all right, we have a lot more of those. The student group sells them at our bookstore, and we can sell them online. And so if you'd like to, we actually offer programming across the community. One's called Exercise Time, where we have students exercise with, or kids from the community can come exercise with ISU athletes or students. We either do that at Forker or some of the local schools. So if you know of parents, or if you have parents, or if you have kids young age, look for those flyers or find out about exercise on our website, exercise.org. So anyway, that's our local pitch, and I thought I'd use this card to give you your prescription for exercise. Whoops, what did I do here? Oh, there's my clicker. All right, so this guy quoted at the bottom, Robert Salas, is the founder of Exercise Medicine. He was the president of ACSM, and he had this vision about 10 years ago, and it's really a major impetus or initiative that really took hold. So again, it was only founded in 2007, so after about 10 years, it's now in 43 countries with large task forces that work to advance this mission across different medical systems, and I'll tell you more about it, and this is why it's still needed. So this is the doctor saying, exercise, exercise, exercise. Yeah, but what should I really do? Tell me what I should really do. And so why is it so hard? Why do people not want to take that advice when it's easy to do? Do you think that's because people have a negative attitude about the word exercise? Because all you have to do is walk. That's physical activity, and that's plenty vigorous for almost all the benefits you would get can come from basically walking. So maybe it's the word exercise that, but somehow the word physical activity as medicine isn't as catchy. So they went with exercise as medicine. So again, this is the way, these are the barriers we face. This is another cute cartoon. You might not be able to read this, but it says, to treat your high blood pressure, diabetes, I'd like you to take this pill, take it for a jog, take it to the gym, take it for a bike ride. So, all right, so you get the idea. So I do want to kind of transition that, and these are quotes from the CDC that say there is no single medicine that comes close to what physical activity can do, and this is from Thomas Frieden, at least the director of the CDC at the time. And so it is a wonder drug, and so that's the effort we're after, to try to get people to take that seriously. So I'm going to move into what the initiative is about and kind of walk you through how the clinical piece unfolds, and then community level and some other steps. So there's 5 steps in the exercise medicine model, and I'll kind of walk you through some of those. But first, let me kind of show you the boilerplate content from the initiative. So again, a multi-organizational, multinational initiative. It's global, to establish physical activity as a standard in healthcare. So they really want physical activity to be taken seriously. So the fact that we now have a Surgeon General's report on physical activity and health helps. The fact that there's national guidelines on physical activity helps, but it really comes down to clinical settings and trying to get the word out to through providers, because you guys have the patient's attention. They'll listen to you. So you've seen these articles or the cartoons. They might not listen to me if I tell them, but they'll listen to you. And so that's really what EIM is about. So the goal is transformational change to institutionalize physical activity assessment and prescription into global healthcare systems. So this shows the countries where there's traction with exercise medicine, again, like 43 some countries where it's taken root, and there's, again, large national task forces that are working to promote the cause. They're pretty organized with how they deliver this, and they're very cognizant of the challenges of how to do this through medical systems, so it's not a naive effort to say, you guys can say, yeah, we don't have time, we're too busy, and I get that, but they've taken that into account, and they've made really simple strategies that are designed for medical systems to implement. And there's a lot of creativity around it. So this is the 3 steps in the clinical component, and then I'll also walk you through some angles on the community side where I talk about what we're doing with our local campaign, and then also talk about active health technology. So many of you are wearing Fitbits, I'm guessing. How many have things on their wrist? Okay, these can be used for mHealth applications as well. So there's a lot of work taking this type of data and streaming it into the clinical process and using it for behavior change programming, and our team does a lot of that work, and so I'll leave you with a little bit of those messages. But first, if you look on the clinical side, there's 3 steps: activity assessment, a prescription, and then self-management or referral. And so again, they've made this really easy. Clinicians assess physical activity during patient visits using a very simple physical activity vital sign. 2 questions, I'll show you that. then they can provide a prescription, a simple, fast prescription. You write out a prescription pad similar to the little handout I gave you. All it takes is a quick little recommendation, be more active, and patients will listen. And there could be follow-up referral to community-based organizations or health coaching applications, and I'll share a little bit about what we're doing there. So the exercise vital or physical activity vital sign looks like this. It's very simple, 2 questions. So on average, how many days per week do you engage in moderate to strenuous exercise, like a brisk walk? 5 days, 2 days. So if somebody says number of days, then they say on average, how many minutes do you engage? And you say 10 minutes, 30 minutes. You just multiply those 2 numbers together and you get minutes per week of physical activity. And so if somebody says 0 days, then obviously they have 0 minutes, and they'd have a score of 0. Those are the people you want to worry about. If people are saying, well, I do 3 days and I'm getting 20 minutes a day, then they're getting 60 minutes a week. That's getting in the ballpark of some health benefits, but you'd want them to do a little bit more. So it's a simple screener that helps you know whether they're even aware of the benefits or if they've tried to do that. So it could be included in a report, and many clinics are now using them built into electronic medical records. So this type of screen will look familiar to you. And this is from a clinic that's using exercise. These questions are built into their EMR report. And so it'd be up to the clinic to figure out how and where this gets done. But again, there's models for how it interfaces with Epic and other platforms. And so again, the questions are easy and ready to go. The prescription, then there's also resources there for providers and clinical teams on, the follow-up. So after you have it in the vital sign, what do you do? So the prescriptions, there's all kinds of resources and actually separate handouts that describe, like if you have a diabetic patient or a chronic pain patient, there's different strategies and forms of exercise that are recommended. Those are all built into these separate handouts. They're available online or through the EIM providers. So again, there's resources there to make this easy. The referral is another step. So ideally in the EIM model, you would take these people and refer them to a community partner or provide follow-up care. And there's all kinds of great resources. And there's our department trains people in this very task. So we have 1,200 students that are in getting a degree in kinesiology and health. A large chunk go on in what's called the pre-health profession, and another chunk go on into physical activity and health promotion. And they're the providers that could work in community settings to deliver physical activity programming for community partners or for park and rec offices. And so these students are trained in how to do this, how to lead group exercise, how to lead community partner or programming. So those are the types of scenarios that they're after. This is just more about the prescription. So I left you this quote. This is from Bob Salas, and he's a physician in the Kaiser Permanente system. And the highlighted quote there says, just what I've talked about, that if this prescription existed, clinics would use it, and Kaiser Permanente is probably the best example of the large clinical healthcare system that has fully integrated the EIM model into their healthcare. So there's all kinds of resources and connections you can go to look up what Kaiser's doing. So then your question would be, does it work? And there's plenty of evidence there too. I don't want to overwhelm you, but I'll show you some screen captures of about 5 different studies that point to this. And again, there's a lot more. And I chose just the major systematic reviews and meta-analyses and major recommendations just to draw your attention to this is very prominent work, and it is getting acted on in the medical literature. So again, I'll show you samples of these 5 bullet points just to show you that people have weighed in on these types of things, and it does work. So the U.S. Preventive Services Task Force is one of the leading groups that public health people go to decide if an intervention is worthwhile or not. Is there evidence to support it? And they've weighed in. They have a very structured review process for how they weight the evidence. And it's really hard to read this, so I'll just kind of read you through it. But it says the following is a list of preventive services that have a rating of A or B. And if you look at this, the Preventive Task Service recommends offering or referring adults who are overweight or obese and have additional cardiovascular disease risk factors to intensive behavioral counseling interventions to promote a healthful diet and activity for cardiovascular disease prevention, grade level B, because it's very difficult to get change to happen. So that's probably the only reason it's B. The evidence is strong enough for it to be clear that it works, but the evidence of our ability to change behavior is still only a B level. That's one bit of evidence. This was an article by the National Institute on Health and care excellence. NICE, I guess, is that how you guys pronounce it? Are you guys familiar with this group? So anyway, they had a review of brief advice. And so if you read the middle line, brief advice is used in this guidance to mean verbal advice, discussion, negotiation, or encouragement with or without written or other support or follow-up. So brief advice could be 30 seconds. And what the evidence shows in 15 studies of randomized controlled trials that there's an increase in self-reported activity even from brief advice. So that means that, even a small dose of action is better than none at all. And people, again, have studied this in randomized controlled trials. If they do something versus nothing, you get bigger outcomes and benefits in groups that received some advice. So that shows that even at that low dose, it works. This was a study that I thought was an interesting title. It caught my attention. So it's the comparative effectiveness of exercise and drug interventions. So if you really wanted to see, okay, I can give a person exercise or drug therapy, and obviously they might still need drug therapy, but exercise is more potent than drugs for stroke and prediabetes. So that means head-to-head, that exercise, if you looked at these odds ratios, any odds ratio over 1 favored exercise as an outcome. So for stroke and prediabetes, of preventing follow-up problems, it was more effective. And so that makes people pay attention. But again, I don't think we should sell exercise as just competing on the head-to-head against the drug, because think of all the other things that it does. It's not just the effects on prediabetes, because it has positive benefits in many other systems and making people feel better, have higher quality of life, and all those things. So, it competes head-to-head, but it has many more benefits. This was a cost-effectiveness study that showed that, the categories at the top there that we're pointing to, and I guess I can draw your attention to these, supervised clinical or primary care supervised walking programs, and some of these clinical steps, prescriptions for inactive adults, very low cost, very high impact. So these are simple community-based strategies that work. And this was another review of the specific physical activity as a vital sign, and it summarized the many different studies where physical activity is included in these clinical systems and points out, again, the efficacy and feasibility of including this in clinical settings. So I can get you access to these articles, or you can find them online, but search physical activity in vital sign or EIM and you'll find tons of literature there. All right, I wanted to shift gears to the actual clinic or community solution, and here I'll focus a little bit more on what our local campus group does, because we are taking steps to be that referral process or the community partner for student health at Iowa State. And so now I'm highlighting step 4 of the model community, and it's the development and training of a community-based physical activity referral network. And our campus is doing that, and our research team that I work with is even taking the student club step a bit further. So we have a health coaching model we call Sidekicks, and we're training students to be health coaches, and then they're providing coaching for ISU students, and we're just taking steps now where our health coaches could be positioned to serve your patients. And so we're actually doing that with Joe Merchant, just starting off really slow with his team, and we have a student health coach that's actually working there this fall. And some of the handouts I have up there, if you happen to grab one, are about that, and I can get it to Sally for additional details. But first I'll describe our outreach. So again, the top part is the student club. We have a really good student organization, and they work really hard to advance this mission. They're really committed to the cause, and we're a silver level EIM OC group as far as ACSM goes. We're trying to move up to gold, and to do that, we have to further substantiate the referral linkage that we have with with our student health center, but we'll be there this year. Then the bottom is 3 Ph.D. students that are dynamos in health coaching. They're really well trained, and they've developed this health coach practicum course that we offer to students and lead this motivational interviewing hub. And we run that through a group we call Wellness Works, but it's in harmony with Exercise is Medicine. So this is our referral system. So we have these prescription pads that the physicians at Thielen Student Health pass out, and they give them a simple way to check that I'd recommend doing aerobic activity or strength training, and on the back is some resources on campus that they could go to. So this is the prescription and referral all in one. Simple thing a clinician can do. So we're still trying to get the actual 2 questions built into the Thielen Student Health Center so that we can say it's truly in their medical system, and it's really difficult. Again, I'd love to work with your system to see, can you guys, or can we get that into the system here as well, and then have a simple referral process that works for your patients. But we're taking this step, and it's easy for the physicians to write out a prescription, and you'd be surprised that students need this information too. And if they hear it from their physician, that's going to increase the likelihood that they pay attention to that. But our real model is that the students then get referred to our student health coaching hub. I had a slide in here of Exertol. I already showed you what that's about. But this is our student peer-led health coaching model called Sidekicks, so it's not coincidental. We played off that word again. So a sidekick is a peer health coach, and we train the student health coaches to provide that service to mainly freshmen and sophomores. So we kind of target upperclassmen, juniors and seniors, to be the health coaches for incoming freshmen or sophomores to get them off to a good start on campus, help them find resources to stay healthy, those kind of things. So this is an example of one of our health coaches. So we have this on the website on the Student Wellness Center, and so a student can see what's involved, and you see that our process involves motivational interviewing, which I'm sure many of you have heard of. Yes? So we train students in motivational interviewing, and it's those of you that are devotees of it, you know it's a skill, and we have a whole class where we train students in this skill, and it's a listening skill. It's basically getting a patient to come up with the ideas for their behavior change on their own. And so we spend 8 weeks training students on MI, and then we let them loose and they practice it with peers. And we follow we track their adherence to the MI principles, and we track the outcomes both from the student level and the coach level to understand the impact of our training model. And we're really pleased with where we're at with that, and the model really does work. The students really stay committed to the MI methods, and we really think it works. So the general process of MI is kind of engaging, focusing, evoking. So you want to get evocative, you want to get the patient to start feeling and taking ownership of their own behavior change, and then make planning, and then you get closure with them. Whoops, I went too far. So this is the actual class. We have 8 weeks showing there where we practice, or 7 weeks, and then they have health coaching sessions with their partner, and this is with their coachee. This is in partnership with Student Wellness and Exercises Medicine. So our lab, our department runs this, but we do this in partnership with our student org and with the Student Wellness Committee, and so we're having a lot of success with that. We're actually taking this to another level. These show some data that just show pre-post changes for physical activity and stress. We don't have control groups that didn't get health coaching. At this point, we're just demonstrating the feasibility of the model. And so sure, maybe there's some social desirability there that people get more active or report less stress. But we're more focused on the training model and documenting evidence that the students are learning MI and that the patients or participants are getting an impact. And these are some quotes that, from the coachees about why the health coaching helped them. And this is what you'd expect. So it made you feel more accountable, short-term goals, easier to meet goals each meeting, helped me open my eyes to my good and bad habits. And so this is what the health coach does. They elicit this impetus to change behavior in the students. We've expanded our model now. So we train these health coaches and through this class. And now we're offering actually clinical health coaching here in McFarland. So we've had some of our students, after they go through coaching a easy peer, let's say, a friendly student, then we train them with another level of training on what it would be like to train a clinical population or to work with a clinical person. And so one of our students is working again with Joe McFarland in the cancer group, and she's doing a great job. And our vision would be that as we train more and more students, we can make them available to any other department in the center, and they could provide that same service. So we'd have to balance how many students we could provide with the potential demand, because I'm sure some of you are thinking, yeah, that'd be great, but we only have so many students. But as as we ramp up, the class is very popular, and students are gaining a health coach certificate. So we view the practicum as kind of the key outcome of the health coach certificate, and they have to do 2 credits of this practicum class to get the certificate, and you guys would be the ideal setting for them to have that practical experience. So again, that's currently going on. We'd like to expand that, and we also offer MI training. So if any of you have wanted to learn MI in a different way, we've taken our package of 8 weeks and put it into an online module, and we've been training extension specialists and other people on campus, and so we have an online approach that we can make available to anyone. And we have grants that we're writing on that dissemination of the MI model. And so we'd love to, entertain, if you're interested in learning about MI and want to try the online class, you can also contact us and let us know, and we could try that out in small pilots and see how that expands. And again, we're building towards where it could count for CEU credits. We're not quite there yet, but that's where we're going with that. So it's all run through Learn at ISU. I'm not sure if any of you are familiar with this, but this is kind of the distance education hub at Iowa State for adult learners or anyone. So you don't have to be a student. You can sign up through ISU Learn, and that's how you'd get enrolled in the class. And so again, we're still kind of in an early phase. It may or may not be up on Learn at ISU, but it'll be there within weeks. So you can look for that down the road. All right, so this last step is step 5, and this is where they cover the issue of wearables, and I don't have a lot of time to get into this. This is what the focus of my talk was about 4 years ago, because I do a lot of work with these activity monitors, but this is also built into the EIM model, and so I'll highlight this. You'll notice at the bottom again it says active health technology, so clinical community integration and utilization of active health technology, so objective monitoring. So the real vision is that the screener, those 2 questions would be that initial conversation starter, and the clinical team could say, well, I'd like you to wear an activity monitor for a week, and then we'll really get a better sense of your activity levels, and if we repeat this in 6 months, we'll see if your activity level's gone up. And so it's just like getting blood draws for a metabolic profile. This would be a physical activity profile that could be coordinated through a clinical system. And again, there's a lot of barriers to work through here, so I'll point out some of those. So this is a schematic of the steps that would be involved in taking data from monitors into the clinical team at the far right. So at the left, it shows a gadget on somebody's wrist, and you first have to get that data into some digital ecosystem software platform. That's what the slide says. So that basically means into a database. And then from there, it's got to get into the EMR, and from there, it's got to get into the healthcare and be able to be acted on by the clinician team in an effective, simple way. So that the challenge we face is how can the complex data from a diverse array of devices, you've seen there's an array of monitors out there, right? Fitbits and Garmins and Apple Watches. So how do you pool all that data and get it into, be harmonized to give people the same information or to quantify their physical activity? And it's really a difficult challenge. So I like to draw this comparison to other vital signs. So with blood pressure, think of the number of devices that exist, and you can go to Walmart and buy a blood pressure cuff, right? But you guys routinely collect it yourself with a better technology and with better technique, right? But it's good for the public to have their own blood pressure monitoring system, and the advantage is that regardless of the many devices, they all have the same metric. So millimeters of mercury, 120/80. So everyone knows their numbers, right? So people don't know what mmHg means, but the public doesn't really have to know. They just know what's a good number and a bad number, and we've trained people over that for years. And the same thing is true with physical activity. There's many devices, but right now one of our challenges, there's different metrics. There's what we call MVPA, and many of you wouldn't know what that is, but we call it moderate to vigorous physical activity. But you can just shorten that to physical activity. And then our unit that we use in public health guidelines is what's called MET minutes. Does anyone know what a MET minute is? So this is the challenge that we face in the field, is a MET minute it's a multiplier of the METs that you're at times the number of minutes. So if you go for a walk, you'd be at like 3 METs, and if you do that for 30 minutes, that's 90 MET minutes. If you went for a run, you can run for, say, 20 minutes, you'd be at 6 METs. So a 6 MET activity of running times 20 minutes gets you 120 MET minutes. So we add up MET minutes across a week, and that's what the physical activity guidelines are based on. And you could say, I could never explain that to patients, but could you explain millimeters of mercury to patients? All you have to tell them is you have to get 500 in a week. I don't care how you get them. You have to get 500 MET minutes, just like what's your systolic and blood or diastolic. They don't need to know what the unit is. They just need to know how to get there. So that's the challenge we face in the field, is the different metrics are really tricky. Steps are also commonly used. People interpret steps, but steps aren't the best indicator because people could swim or bike, and there's all kinds of challenges with steps. They're commonly interpreted. People know what a step is. And so those are the things that we wrestle with in trying to get mobile health devices to be used in clinical settings. But again, we're working on it. So there's a lot of frontiers in activity monitoring. This just shows you machine learning methods. So the new technology in these devices takes the raw data from an accelerometer count, and it filters it, processes it, and it can identify if you're walking, it can identify if you're not walking, it can identify if the pace is faster that it's running, and it can differentiate different types of data. Just like there's voice recognition, there's pattern recognition, and this technology is really taking off and making it easier to quantify the amount and intensity of activity. But then, and this is another example of that just shows, pooling data from different devices and being able to differentiate sedentary time from light activity from physical activity. And there's a lot of, many more applications of this. But getting back to the model, the challenge is how do you take all these technologies and get them into one system in a common way, like blood pressure. So they all have to have the same unit for us to be talking with each other. And there's a couple approaches. Unfortunately, there's some technology. There's, HDF4 or HDF, that version 5, that's a common language that helps data get into EMR systems. And so people are playing with that. And then, the physical activity people are also working with LOINC codes, which are obviously something you guys know about in your EMR systems that can be used to track indicators. So eventually it has to get into the EMR and be coded somewhere. Whoops, I went too fast again. So really there's two different approaches. There's different gadgets, so people can have different things on their wrist. So one approach is to standardize based on the processing that goes into that database system. The other is to just standardize the outcomes, each device reporting MET minutes, and those go into some database, and then you standardize at the EMR level. But, so there's two approaches, and people are wrestling with how do we take data from all these different gadgets, how do we ensure that the gadgets are all good, and how do we then use that information to provide or promote clinical counseling. And so this is a single slide again that talks about smart on fire applications. So these are, again, applications that are designed to do this. And there's a lot of really smart people that are working on these technologies that enable integration of this data. So again, the gadgets on your upper left go into some database, and through fire technology move into an app that you can see. And these are available and can move into EMR systems. And I worked with some colleagues at Georgia Tech on this, and they had this schematic, which is very similar. So there's wearable devices that move into a database. The server then takes it and puts it onto the Smart on Fire app to visualize what the outcomes are. And they've got proof of concept that this works. So again, you take data from your wrist, it funnels through in this messy graph in the middle, shows you the complexity of that. And on the right, you end up with visualized summaries of moderate to vigorous physical activity on different days, just total amounts of MVPA. And again, we have to struggle with the units, but this is the kind of technology that is coming down the road. So I like to highlight in this middle slide, like what you're wearing on your wrist, it is literally capturing 8.6 million data points a day. Because most of these devices are sampling at 100 hertz, and it's collecting all that data. It's not showing it to you, but it's capturing typically at 100 hertz that many signals. And so to do these data processing routines, it has to be done on the front end and give a simple unit or one number that comes into the EMR system, so it avoids clogging up large databases with that volume of data. So the vision again would be a screening with physical activity vital signs, so simple 2-item questions or two items that would capture the pulse of a person's activity profile, possibly follow-up referral with week-long monitoring to really get a sense of that person's activity. And then maybe the data comes up and you could give a person, well, here's your profile and here's what we'd recommend. And then maybe there's referral to a clinical health coach that would then help that person create behavior change, or referral to a community partner. So again, that's the vision. It's not easy to get there, but that's where I think the field's going. And so I'll just conclude and give you my final take that exercise really is medicine, but I hope you also see it as a lot more than that. And again, there's a lot of potential for this swirling connection between technology, healthcare, and the consumer. What people are wearing in that whole M-Health world is really going to take off. So I hope I answered some questions, gave you some things to think about, and I'm happy to field any questions you might have. Thanks.
Thank you for that inspiring remarks. I'm thinking about keeping my car parked here and going home. So, but anyway, I just a comment and then a brief question. A summer ago, I had the opportunity to look at the facilities and the initiatives and investigation going on in the Foraker building, And I think everybody in this room should be not only impressed with the comments in the lecture today, but the amount of research and investigation going on in kinesiology on this campus in the absence of a medical school is truly phenomenal.
Great.
It rivals any medical school in this country. It really does. My question is, you showed some numbers in regards to how many minutes per day exercising and number of days per week exercising. Most people that I know that exercise on a regular basis want to do it 7 days a week, but there must be, maybe you have a comment about how often one should take a break, 1 day a week or 2 days a week, to let the muscles kind of reboot themselves and relax. So, I mean, do you have a recommendation on how often you should just take a day off?
Sure. I mean, I mean, we specialize and train students in physical activity prescription, and it's individual, right? So if you're serious and really want to improve, people can exercise 6 days a week. There's still a value of taking a day off, letting your body recover, but serious athletes even do periodization, where they train differently in 3 straight weeks, and then they take a week where they lower their intensity. So there's different methods, but with a new individual, you'd start them with where they're at, and so maybe 3 days a week is better than 0. So you wouldn't start a person and say, I want you to exercise 5 days a week if they haven't done that before. So just doing something on 3 days a week is a really good start, and starting with walking is the best recommendation. So you're avoiding, don't try to tell a person that they should exercise. A lot of people carry a lot of baggage about what they experienced as a kid or in physical education, unfortunately, that they say, I just don't like that, or I don't want to sweat, but fit walking is fine. The other initiative that's happening in the new physical activity guidelines will probably move away from what we call bouts. So the current guidelines say that you should have physical activity in 10-minute bouts. That's a convenient number. And that was a step. We used to tell people you have to keep your heart rate in the target zone for 30 minutes, and you'd see people running at traffic lights, right? Have you guys seen people do this? Well, you can stop. You can wait for the light to change. The benefit doesn't matter if it's 30 consecutive minutes or 29 minutes and then another extra minute after that. So that's what we trained people to do, is think that they had to do that vigorous for 30 minutes in a row. And then we changed it to realize, you can exercise in 3 10-minute bouts, and the field's moving to where no bouts. It doesn't matter. It's the accumulation of total volume of physical activity that matters. So it's the short breaks throughout a day all add up. So I don't know if I've answered your question, but it depends on the individual. Start slow. Walking is the best initiative to start with, and 1 day a week is a good recommendation.
Thank you. One other just brief comment. For those that are members of the Alumni Association, this current issue of Visions is completely dedicated to the well-being of and the research that's being done in human medicine here on campus. So you may want to get a copy of the Vision magazine.
Great. Yeah.
It's all about motivation, too.
Yeah.
15 years, my last 15 years of practice, I've walked to work night, all year, except when it rained. Mm-hmm. One of the best things I ever did.
Yep.
But I had a place to go.
Right.
And what about people to motivate them? These devices are not free. Mm-hmm. Suppose you had a device that you could give to a person for a week to see, to convince them that their activity level really needed enhancing.
Yep.
Have you tried that?
Yeah, we do that. So actually we have a study we called the Fitbit study, and one of the colleagues here, this is our research team in the Physical Activity Health Promotion Lab, but we had the Fitbit study. We gave people Fitbits for 6 months, and we studied and tried to figure out when do they stop using them, because we know that eventually the novelty might wear off. But we had 2 groups. One group got simple motivational interviewing for at the beginning, and then every month we followed up to see if we can impact their motivation a little bit. But we've done other studies where we have them wear a monitor for a week, just like I'm describing, give them an MI session, and then send them on their way and say, these are the recommendations for how to be physically active, and try to find ways to do that. And then we follow up with them 3 months or 6 months later to see if those took root or held on. So we do a lot of work in that realm with health coaching, and what we call facilitated health coaching is trying to give a little bit more benefit to just taking a monitor out of a box and using it. So how do you use it? How do you set goals with it? Yeah, good idea.
All right, so this is always kind of a provocative question, but what I'm kind of interested in is a measurement of fitness. And, Mayo Clinic spends a lot of time and writes lots of articles about is this person physically fit? What is cardiovascular fitness? and your conversation has been about physical activity. What is the correlation? So in other words, theoretically, you can take some slug who hasn't done anything, and you put him on a treadmill, and he's fit, and in which case doing all this physical activity would be kind of pointless. So my question is there some kind of correlation or relationship, to measure the benefit of the physical activity to a person's intrinsic physical fitness? It does happen,
Sure.
There are people that don't do much and they get on a treadmill and they look
right.
just fine.
Yeah, there's a genetic component to fitness that some people are more fit than others, but physical activity is the behavior that leads to fitness and sustains it. So, but they both have independent effects. You're right that a base level of fitness provides some health benefit, but physical activity also provides an additive benefit. So you can take a fit person. It's similar to the slides I showed about body composition. You can have a fit person, and then if they're a fit person but inactive, they're going to be at greater risk than a fit person who's active. And we have that same concept now evolving with the issue of sedentary time. So you can go out for your morning jog, and then if you sit all day in your office, you might say, I already exercised today, I'm good for the day, I can sit all day. Well, not really, because now we know that sedentary time has an independent effect on physical activity, and so you have to look for ways to minimize sedentary time as well. So both sedentary and sedentary behavior and physical activity are independent, and physical activity is also independent of fitness in a way. The way that physical activity works is it's more of a daily dose, and it kind of links to metabolic fitness with glucose regulation and things, and fitness doesn't really do that. So that's why one of the independent components is that physical activity keeps your metabolism going and keeps your brain going and your other things, and you need that daily dose, where fitness is like a state. It's you have it, but that doesn't provide those in daily sparks to the system. I was going to add one thing about the fitness. So there's actually work with these devices that can estimate fitness. So from physical activity and heart rate. So some of your devices have heart rate sensors, and you can estimate fitness directly from some of these devices now.
Back row again,
Yep.
over on to your left.
It's hard to tell where you guys are talking from.
So Dr. Spencer taught us that we can prevent dementia with exercise.
Yeah.
And you taught us about the impact on diabetes, development, and management with exercise. And I was just wondering, is anybody doing any research into lifelong earning potential? Because I know money motivates people.
Sure.
I mean, we know exercise improves sex life, so you'd think that would improve people's motivation, but
Yep.
unless it's impacting you right then, like you have a loved one who got diabetes or got dementia,
Sure.
it doesn't seem to change behavior, but money might.
Sure. Yeah, there's people that have played with the words wealth, health, that they are correlated, but then it's very difficult to separate out, socioeconomic factors and, mental abilities and acuities and, paint that or link that to the physical activity that's performed. So the causal chain is really complicated there to say, is it physical activity that caused that wealth? Or, but I think we all know that we might think better or feel better after a walk. I know that for me, I go for the walk, and all of a sudden the idea pops into my head, and it's crystal clear. Unfortunately, by the time I get home, I forgot to write it down. Or, does that happen to any of you? But it's amazing how those thoughts just pop into your head. So a lot of companies are embracing this, and they want, there's active workstations, and they're trying to promote more mobile or moving meetings, and so they're aware of that we think better and work better when we're active, and I think that plays into the wealth thing, that you're more productive, more confident, and some of that.
You also get health insurance discounts
Yeah.
if you're below a certain BMI, so
Sure.
that's a money motivator.
Yeah, that's true. And worksite, it would be nice if work sites had a stronger benefit for tracking physical activity, and there's a lot of efforts going into building these incentive systems for work sites so that they can offer employees those benefits and reward them, and they do. So I know a lot of companies are doing good things there.
Hi, love the talk. I was curious, I feel like I hear a lot of different information on weightlifting versus aerobic exercise, and I was wondering if you can kind of speak to that. Is one more beneficial than the other?
Sure.
I know some people that just weightlift all week.
They both work. They both work in different ways, and so the combination of both is better. So there, many of you, I bet there's somebody in the audience that's in our cardio race study in Forker. Is there anyone in here? Couple, good. So you're in a trial that's evaluating that very question. You might not have been told that, but the cardio race is one of our prominent trials. It's run by DC Lee in our department, a large NIH-funded trial, and it's answering that question because people were randomized either into an aerobic group, a weightlifting group, or a combination, and we've standardized the dose, or DC has, standardized the dose that they get in a way that we can point or test those factors. We think all of them are going to be beneficial, but we'll find out, does some work better for certain conditions than others and things like that. So the answer, and I routinely ask students this, some people can adhere to aerobic exercise better than weightlifting. Other people are exactly the opposite, and they like resistance exercise but find it hard to go out and walk or work out aerobically. So I think it's individual. So I guess I don't have an answer of which is better, but both are good. Yep.
Two questions. If you are totally immobilized, let's say you break your hip, in a week, what % of your muscle mass do you lose? And the second question is, regardless of age, can you do things to increase muscle mass?
The answer to the second question is definitely yes. So you can, at any age, you can increase muscle mass, and with even low intensity resistance exercise can help. And it's also the functional benefits that come along. So the muscle mass is important for burning more calories and things, but the functional aspects of physical activity are really, really important. So the first question, I can't give you a number of decline, but they have done bed rest studies, my dad's favorite expression is 7 days without exercise makes 1 week. But, that's my dad's sense of humor. But so he would say 7 days without eating makes 1 week. But so the week is the play on words. And so, 7 days of bed rest, you would see significant declines in function even in 7 days. And they've done studies on this with astronauts and things, and there's a lot of challenges about space travel, about keeping their bone health good and avoiding or, dealing with the immobility of like space travel and hospital patients. So getting them moving is really important, keeping them moving. So I don't have a specific number, but it would be within 7 to 14 days you'd see significant declines. Yep.
So I've sent several of my patients over to Cardio Race, and they really enjoyed that. So thank you for doing that. I'm looking forward to seeing the results for that. But I have a question about whether there's any studies that, for kind of along the lines of what Dr. Spencer was saying, is there a blood test or anything like that that can show activity level or anything like that? Because there's nothing that I'm aware of, but whether they're more of a functional test, because we kind of know the limitations of like Fitbits. My sister types rapidly enough, and she can get her Fitbit to give her steps, and some people that talk with their hands the whole time can, all of a sudden they're walking a whole lot. And there's limitations with the sensitivity of that. Is there anything upcoming for a blood test that can tell physical activity?
Yeah, not a blood test, but again, that's why the focus is on a self-report screener. That gives you really good information on, if a person's not lying, you get really good information from how many days, how many minutes. So a lot of times people are attracted to the technology and all the gadgets from a Fitbit, but it's almost harder to get clean information. So those two questions can almost give you more information than, really the best information in that context. Are you active or not? Or a little bit or a lot? And you could really get an idea of what a person's behavior is rather than using a blood test to try to infer that. But that's the area I study is, physical activity assessment, trying to figure out how do you take the data from these different devices and how do you make meaningful outcomes. So it's really the motion sensors, these accelerometers are our best available tool. So not a blood indicator, but it's the motion sensors that we're getting really good at quantifying the amount and intensity of activity that people perform.
Hopefully there's just been a few stories of people hooking them up to their dogs so they can get the things like
if there's
that.
an incentive to do so, people will find those ways. But the other challenge is that now the public, people have been in the research community. We've been using accelerometers for 25 years, and it's only the last 10 that these Fitbits have been out to the consumer, and so they are not as accurate, and they have worse challenges interpreting the data. And also, these companies don't share their algorithms with researchers or clinicians. So you don't really know if they work or not. You buy it off the shelf and say, "Oh, this is telling me my activity," but how do you know? And so we do studies to kind of quantify the error in these devices versus research grade monitors, and so that's an area I study a lot.
Interesting. Thank you.
Yep.
I just have a comment about like the Fitbit, Apple Watch, Garmin thing. Those are kind of expensive, as I can't remember who. Dr. Bannett pointed out. I had a Fitbit which failed twice in a little over a year. So the next time I got a smartwatch device, which seems to count my steps just as well, maybe not quite as accurate on my pulse, but it's lasted for like 2 years now and never failed. And it's easy to plug in. You use it right. So people don't get hung up on Fitbit or one of those brand names. I got mine on Amazon smartwatch, and it's worked great.
Yeah. That's, I think, where, it's on my wrist as well, so I have a Garmin, but, they do work well, and they can be a cue or a reminder, but certain people, like, I'm going to get out and be active whether my watch is reminding me to track it or not, so sometimes we become a slave to our data and stuff, but it's a nice cue and a reminder of steps per day and things like that. But yeah, I think the prices will come down, but you get what you pay for, but, that's 2 years is a pretty good outcome. So a lot of people say, well, it wore out. Well, a lot of things wear out. We can't use our computers from 2 years ago either. And so, you eventually have to, keep upgrading your technology, unfortunately.
I have one more question for you.
Sure.
Can you speak to, I was just thinking about this when that woman was asking about blood monitoring. Have there been studies that look at, let's say you get an initial blood pressure and lipid levels, I'm trying to think of other things you could do, glucose, things like that, and then the patients start exercising, and then you monitor, how long does it take for things to decrease or normalize, things like that. And then if so, could we potentially, I'm thinking really big here, but somehow monetize this and incentivize people so they'd get a lower insurance rate if they were able to do this? That's big.
The answer is yes on all those. That's what all these clinical trials do. So there's many clinical trials that quantify those doses. So the cardio race is an example. So they do measure everything. I'm sure you guys had to go through very complete metabolic profiles, fitness tests, and then we look at dose, and then those outcomes will be published and to say what is the dose needed to be active. And we know what the dose is, but the cardio race study will add new information. So we know the impact of 30 minutes of physical activity a day is about what you need to get a really significant health benefit, and it can be just walking for most people. So that adds up to to meet the physical activity guidelines I talked about of MET minutes, you'd meet the guideline with that. And so we know the dose, but it's just specific for each risk factor. So you might, if your goal is to reduce blood pressure or glucose, there might be different intensities, and weight loss is another one that the prescription would be slightly different if your goal is to exercise for weight loss. But then the insurance question is a huge one, and you got to get the big insurance companies to start seeing that benefit and incentivizing companies to do it. All right, thank you. Feel free to take some extra Exertol bottles if you have colleagues that would like one, or they're there for you to take if you want a couple extra.